admin stuff first of all. The meeting's being live streamed to the public, and a recording will be available on the council website within 24 hours. It's a hybrid meeting, as you can see, so participants will be joining remotely. If remote participants could use their hand up icon to indicate if they have a question or if they want to talk. You're required to wear masks if on entry and if standing, but you may remove them when seated. Microphones, when you want to speak, can you switch on the push to talk button and speak closely to the microphone? And switch off your microphone when you finish speaking. Okay. Apologies for absence, but.
Yes, Chair, we have apologies from Councillor Pitts.
Thank you. Minutes of the last meeting. Trust everyone's had a chance to read the minutes. And everything is okay. Thank you. Okay, if I can just give a quick update. So you might be aware that the intention is that I'll be involved in meetings with the Corporate Director for Population Wellbeing and in regular meetings with the Chair of the Health and Wellbeing Board and the key portfolio holders to talk about any relevant issues to do with those bodies and how they link into the work of the HSCRG. Hopefully you'll have seen the table that's been produced as part of that work that is intended to help decide goes to what meeting between this group, the executive and the Health and Wellbeing Board. This has been circulated to assist partners and hopefully we'll find that helpful. You'll have noticed that some of the scheduled update reports are not coming to this meeting. I'll just give a quick update on those. For the integrated care system, the Health and Social Care Bill is at the committee stage in Parliament, which will put the ICS on a statutory footing. This bill provides for the Care Quality Commission to assess how local authorities deliver adult social care and changes to the way ongoing care is coordinated when patients are discharged from hospital. I'm sure we'll want to look at some of the wider implications of the bill at a future meeting. The bill is likely to return to Parliament in November, so it'll be presumably sometime around then. At BLMK level, the ICS is looking to set up in shadow form from late autumn, and the Council's involvement in the ICS will be considered by the executive. We will have an opportunity to review this when it goes to the executive. Chair of the ICS, Dr. Rima Makaram, remains in place, and the chief executive role will be the subject of a national recruitment process. Going on to the joint strategic needs assessment update. The business intelligence team has been supporting COVID analysis and the recent Ofsted visits. So they have not had the capacity to progress any JSNA data analysis. To help with this, recruitment is taking place for additional analysis post in the BIT. The JSNA will also need to include consideration of the wider impacts of COVID on health inequalities, and further work is being undertaken on this. The resulting updates will come to our group for consideration. And finally, the Population Wellbeing Action Plan updates. The Population Wellbeing Strategy will be updated to reflect the changed position from the COVID pandemic. Priority is to update the strategy and then to amend the action plan. The updated plan will come to the review group for consideration. The Health and Wellbeing Board has developed a recovery plan, and this has also been circulated to the group. Okay, thank you. Disclosures of interest. Anyone? Okay, let's go on to item number 7, update on COVID-19 in Luton. Laura?
So I'm sure you'll appreciate there's been a very busy time for the public health team over the last few months. And as we're in the summer, we're beginning to see people take their holiday. So you have me tonight to give you the update on the COVID paper. So there's information on it on what is happening in Luton. But if I just give you the latest figures, we are tracking below the England average. And if you look at the tables at the moment, we're on 144th in England. Numbers are declining, but we are still seeing higher prevalence in our population. So we're still really pushing the key messages around keep on doing the twice a week testing, and we're still providing the service on LFTs for people to pick up the test kits and also to have an observed test. So we're really keen to promote that and continue to do so. We're really keen again to promote the message about hands, face, space. And if you're in a crowded space, wear your mask, keep your social distancing, keep using hand sanitizer and washing your hands. So really important messages. You'll know and you'll see that some of the government guidance has been changing. The national contain guidance was reissued for local authorities, was reissued only on Tuesday. And updating in relation to what they're expecting from local authorities. So we will have to think about that as well. You will know that we've started some new initiatives, but the testing bus is still out and about. You can see it in St George's Square, and it's also going about in community locations. More people are actually picking up test kits to take them home. So we hope that they are doing their twice weekly testing, or if they think that they're going to see, we think some people are using it, if they're going to see someone vulnerable, they're thinking about taking a test. So we're seeing still good take up of that. We're just awaiting some further guidance from the national government on how that's going to progress. And as you know, you've had an opportunity to look at our contain outbreak management funding, and you will know that we've still continued to put resources in around the work around testing. So the other area that I think is a key priority for us is around encouraging take up of vaccination. And I will hand over to my colleague in the CCG. To talk about that in a bit more detail, but it's really important and to get those messages out. You will have heard yourselves tonight that the age range will be extended to cover 16 and 17-year-olds as an announcement. In terms of younger people taking up the vaccine in Luton, our numbers are low. So it is really important that we continue to give some of those messages out. So anything that you can support on continuing with that work is really important. But I will hand over to Nikki to give you a bit more update on vaccination.
So I wasn't expecting, however, as it's a daily event, I think the progress that we're making is we are still having residents coming forward for the first, and we were commended by region that we are clearly still making that offer out. So I cannot in any way underestimate. It is encouraging, and the work that we are doing collaboratively is to try and get young people who have had the vaccine to encourage peers, and that seems to be really a very effective way. Equally, if any of us have got young people that we know that have had it, it is really to try and get that movement going. We're still where we're moving now with clearly the phase 3 that you will have heard of, which we now know is going to start from the 5th of September. But what we need everyone to be aware, if you haven't had your first or the second, it's got an acronym calling the Evergreen offer, is that there will be that provision. So if people decide late that they are then happy, there will be absolutely no reason why people can't come forward. So we have to keep working through that. In the last 2 or 3 days, there's some really focused work on people who are pregnant. And we've got colleagues in the CCG, particularly a lady, Sunita Chakrabarti, that I know has spoken to colleagues in LBC. There is really a big evidence base. It is really advisable for those expectant mums to have the vaccine. So there's some excellent work with the midwives and the health visitors. So if anyone wants any guidance on the website to the CCG, there's some good links. But again, using our generic email address, if people want it, we will do a very tailored, personalised approach. So we are continuing to progress, but it is slow, and I think really that's what Laura's saying. So it's how we can do that supporting. Website again, it will explain where the sites are. The primary care networks, the GP practices, they have all in Luton completed what we'd asked them to do. So it is now the vaccination centres and the community pharmacists. The very good news is that the community pharmacy model has been really successful and really popular with our local residents. And that is something with the phase 3 we're going to progress further. So very happy to take any questions.
Thank you both. Anyone? Councillor Campbell?
You said that the infection rate is 140 something per 100,000?
No, that's our position in the England rankings. If you give me a moment, I can give you the up-to-date position, but we are some way down the England rankings.
In the document, it says 322 people per 100,000 on the 20th of July.
If it helps, I've got the figures right here because they were sent to me earlier. So the Luton rate was 271 per 100,000 population. So at the moment, that is lower slightly than our neighbouring Bedford Borough, Central Bedfordshire, Milton Keynes. So at the moment, we are. I mean, they're all very similar, but we are the lowest at the moment. Yeah.
And on that figure of 271, we had seen a 21% reduction from the previous week, which is how the figures are done.
Pat?
Nikki, you might have said this, I might have missed this. Phase 3, will it be a walk-in or will you get an appointment? Will there be a timescale from when you had the previous one?
So the phase 3 is a whole new programme for us, and we will absolutely, so we're going to use all the lessons learnt from the first phase 1 and 2. So there will be a whole combination. We know that just walk-ins are more popular, so we absolutely will have that in the model. We will also be working very, very closely with the public health team to be doing what we call the pop-up, so really targeting and focusing. We know are hard to reach, so we know we've got quite a number of asylum seekers, so we are really targeting onto all those vulnerable people. Yeah.
You know, I work at sixth form. Could you target the colleges?
That would. So I assure you that all the principles are absolutely key. We were just saying in our team meeting this morning that sometimes we hear the first about the 16, 17-year-olds through the national media. We knew it may be coming, but we just have to do those checks and balances. We have to do these protocols to make sure that all the people are trained. So that communication will come, and we'll hopefully get that commenced ASAP. But yeah, with the schools and your contacts, fantastic.
We have an enrolment week, and I'll tell you, it's the 31st of August. For 1 week is enrolment week, so that might be a good week.
I will take that immediately back. That is fantastic. Yeah, super.
Anyone else? Councillor Blackburn.
Thank you. First of all, I'd like to thank Laura Church for all her hard work in supporting us. It's a shame to see you leave, and I'm sure on behalf of all of us, we're going to really miss you. It's our loss that you're going to Bedford. I wish there was anything we can do to keep you here. My question was, you compared us to the neighboring boroughs in terms of vaccination uptake. In terms of the youth, is it correct to say that Luton has a younger population than around us? Therefore, are we comparing the uptake of the youth as well to see whether we are lacking? And if we are, what we are doing to support the uptake of vaccines in the youth? Thank you.
So I think this will be a double act with Nikki, because how you work out the population that needs to be vaccinated is something that we've been talking about. In terms of working to encourage young people to take up the vaccine, it is something that we're working on. As you know, we have our serious incident management team within Luton. We have agreed that we will have the meeting on Tuesday next week to look at vaccination, look at some additional marketing and other types of campaigns directly targeted at young people to really drive some of those messages. But for young people, I think that we are being looked at in comparison with other towns with a similar demographic, and it is all of those places with younger populations that seem to have a lower rate of uptake. So actually, maybe one of the things that you'd like to do as the review group is to ask some more questions about that when we've developed our plans and our thinking. And I know we'd be happy to come back and talk about that in a bit more detail. Hope that answered. Did it?
Yeah, on here. Okay. Yeah.
So you're specific about the numbers and the younger population, yes. Part of my role is making sure that the GP practice list numbers are accurate. So I have done quite a little bit of work with that with regional colleagues about how we make sure that people that are on the GP register are here. So I'm very confident it is as up to date, but we do know that the population in Luton is more mobile. So there will always be a small lag time. So when we compare with some of the ONS, the Office of National Statistics data, it could appear that we're doing slightly better. But that's not to be complacent, because we need to be working to get everybody vaccinated. So for us, we're working really collaboratively to just try, because we really are aiming for that 90%. And there's quite a variation amongst, if we look at 18 to 25, there's quite a variation between 26 and 30. So when you cut the data, we're really just trying to target interventions to the age groups, because they're all slightly different.
And as SIMT, we'd picked up that there's an opportunity to work with the college on its return and with the university to really have some locations where there will be younger people to offer them the vaccination. So we are looking at all of those opportunities. So if you have any ideas or particular groups that you think, well, actually, this group might be interested if we could do something different, by all means suggest it, because we're very open to looking at different ways. As you know, we piloted the bus, we've piloted pop-up sessions with the support from the CCG. We've really got the local pharmacists, which has been doing really well. So if you've got anything, everyone can have a good idea and to feed into this. It's really important that we get as many people vaccinated as possible.
Symptoms, as we know, with the Delta now, the symptoms are not the classical Kent symptoms, which is the new cough, high temperature, and loss of smell. Have we sent message out to the youth to say, look, with the Delta, this is what we should be doing? But I think it's really important that people who are asymptomatic can go about and then not knowing that the Delta has different symptoms in case you're infected. And then this is going to pick up. I mean, very soon winter will be falling on us. And if people don't know their symptoms, I think that would be very difficult. So we should be out there promoting that, look, there's no other classical symptoms anymore. These are the symptoms, and people should be aware. I'm not sure, I haven't seen any literature to that effect. So if maybe it's in the pipeline, I'm not sure about, are we going to promote that in terms of the youth? Because again, the youth, there's a reluctance to say, for me, I don't see the reason because I'm not going to end up in hospital and I'm not going to die. The chances are I'm just going to recover. But there are people who are vulnerable, the elderly and stuff. My fear is, as you know, the first jabs occurred in December. With time, immunity wanes. And people who have had the double jabs have ended up in hospital. And my fear is going to be a cycle where the elderly who had it initially around December, their immune system has gone down, and nobody's telling people that, don't be so, I'm not going to say stupid, brave to say, I haven't got it, but you can give it to somebody else. That's why I think that message needs to go out. So my question is the message going out to the youth to say that symptoms have changed?
I think the messages have gone through. I will take yours back because it's always helpful. I think the message to the younger people is that it's very much protecting your family and who may be vulnerable, so grandparents, parents, if they're older. So that message has, but again, it's helpful. Your point is, it's just allowed me to remember about some patient stories, because we know, or resident stories, and I will go back to my comms team and suggest that we do one of a story of that you didn't know you had symptoms, because we will probably find somebody who didn't know they had symptoms and found out they had COVID, and perhaps with somebody, had they known they'd had COVID, they wouldn't have gone there. So a very helpful point, and I'll take that back to the comms team.
Councillor Akbar?
Yes, I don't know whether this is correct or not, but I have been told one of the doctors in the hospital, L&D hospital, that the admission rate is from the younger age group. Is that correct?
I've certainly heard that on the national news with some evidence. I wouldn't know specifically on our Luton and Dunstable data, but I could certainly find that for you. I absolutely know we as a team are monitoring whether people have been double jabbed and requiring ventilation. And as of last week, that wasn't their case at all. So I know the consensus is it's people who haven't been vaccinated who are in hospital. But if you want specific age groups, I'm sure I could find that for you.
I think that would be helpful because we have concern that the younger age group are not actually having vaccinated, and then they end up admitting in the hospital. I mean, that's certainly what the comms teams have been emphasising. It is the people who have not been double jabbed that are the cohorts of patients requiring hospital care. So, yep, I'll happily to do that for you.
Thank you. Anyone else? Okay, thank you both. And we'll go on to item 8, updates on the provision of NHS dental services in Luton. And this is David.
Yes, hello. Chair, thank you. And I have my colleague Tom Norfolk with me. Tom is a practicing dentist and also chair of the local dental network covering your part of the region. The paper is as read, but we thought we might talk to some important points behind it if we might, and then grateful to answer any questions that you'll have for us. As you'll be aware, dentistry was suspended back last year in March and stayed suspended until the 8th of June, both NHS and private practices. And NHS England brought into place eventually about 100 urgent dental centres that could see patients. And the effect of COVID, effectively, with dentists working about a foot away from a patient's airway, meant that there was a possibility that dental practices could become super spreaders. So dentistry was closed for a while and just the urgent dental centres were in operation. As we moved through to the 8th of June and beyond, although practices throughout the region reopened, the actual throughput of patients, which would have been anywhere between 30 and 40 patients per day per dentist, was dramatically reduced because of the need to implement fallow time, so that the aerosol that is produced when dentists use their drills would have time to settle and then the surgery be cleaned prior to the next patient coming through. And that reduced the throughput to 5, 6, 7, 8 patients per dentist per day. So we were seeing much less access to patients because of the need to safely, not only for the patient, but also for the clinical team, be able to deliver those services effectively. And so from dentistry reopening on the 8th of June, really through to the end of the year, December, practices were allowed to deliver about 20% as a minimum of their usual contract throughput. In January through to March, so the fourth quarter, that changed to 45%. And then from April the 1st, for the first half of this year, so through to October, practices are being asked to deliver at least a minimum of 60% of their normal throughput. Although social distancing measures have relaxed, the same SOPs, standard operating procedures, and IPC, infection protection control protocol, still needs to be followed by dental surgeries. And so that has shown a reduction in access to dentistry, hence the guidance of the Chief Dental Officer, Sarah Hurley, to all practices is that they prioritise the needs of patients, with urgent patients, those that are in pain, being seen first. And that might mean that some regular attenders to dental practices might need to wait longer for routine checkups. On the backdrop of all of this, during that COVID year, the dental team have been quite busy in terms of a dental strategy. The strategy that we have outlines 3 pillars: 1, increasing access; 2, reducing inequalities; and thirdly, improving the oral health outcomes of patients. That strategy was signed off probably almost a year ago now, and we've been enacting it, where we're asking practices to deliver their contracts slightly differently, and we're remunerating the providers slightly differently for seeing the right categories of patients. The current contract that was brought into place between 2004, 5 and 6 for dentists really works on a system of units of dental activity, and that really has not benefited patients or probably the profession over those years. And so Central Department of Health had for many years prototypes running, and those dental prototypes were to affect a new dental contract that is not yet in place. But we've taken in the East of England a lot of the data from those prototypes and a lot of the ways that they work to increase access, reduce inequality and improve oral health outcomes of patients. A lot of that is within our dental strategy. And then, of course, we're doing a lot with regards to dental workforce as well. Maybe I can pause and let Tom Norfolk talk to our dental workforce strategy.
Yeah, thanks, David. So essentially, one of the limiting factors of access to dentistry is the sort of getting dentists who can work within primary care dental practices, and so we're widening the skills mix. If you've been to a GP practice 20, 30 years ago, you'd have seen lots of GPs and maybe one or two nurses. Now GP practices are very dynamic. They have a wide variety of people with different skills. Nurse practitioners, prescribers, phlebotomists, a variety, and dental practices haven't moved in the same way. And so we're widening the skills mix. We're developing and training a lot more dental care professionals, so upskilled dental nurses, to provide that prevention. We can't drill our way out of this problem. Dental disease is largely inflicted by sugar, causing decay and gum disease, oral hygiene, and so prevention is incredibly important, as it is with many of the general health diseases. And so we're working on a preventative method to improve that by using a wider skills mix, as well as all the dentists and everything else. So we provide a lot of opportunities for dentists and the wider healthcare professionals to actually sort of engage in NHS dentistry and improve the health outcomes, as David said.
Thank you. It's really, Chair, any questions that you or your committee might have?
Thank you. Yes. Any questions? Yeah, Councillor, I believe.
In terms of capacity, you talked about 60% currently. Do you have the timeline as to when we're going to ramp up to between 80 to 90? Because already Luton, we don't have the best dental care. People were doing DIY some years back, a few years back. So how are we going to catch up as we are currently doing the urgent one? We don't want this to continue, so we need to have timelines. And how do we compare with the neighboring or like towns that we have?
That's a good question. So the minimum percentage is England-wide, and that was agreed with the dental unions, with the Chief Dental Officer, Sarah Hurley, and Central NHS England. So every single dental practice across the whole of England has that minimum target of 60%. I probably will find that sort of sometime late August, September, the Department of Health and Sarah Hurley as Chief Dental Officer will make an announcement to the profession with regards to the targeted percentage of delivery for practices for either the third quarter or both the third and fourth quarters of this year. I guess that depends on a lot of factors. It depends on how things are going in terms of COVID and the safety for practices to be able to see more patients. Currently, the SOPs, standard operating procedures, and all the infection control protocol that was put in place for COVID is still in place. And that's why practices are allowed to see a minimum of 60% of their usual patients. Our hopes are that that figure will increase, but there is no time frame for it to increase other than we would expect an announcement to the profession sometime late August or early September in terms of the percentage going forward.
Keep hearing that the minimum, and I think residents in this town are fed up having to hear that we only get the minimum service. We want the best service, and we shouldn't be aspiring to just reach the minimum. And I hope that's not what you're saying, because it will be a shame that our residents should be looking forward to the minimum service, not the best service. Thank you.
Certainly, Chair, if I could come back on that good point. We're assured that all the practices that deliver NHS dental contracts within your part of the region are delivering quality services. So the percentage isn't a measurement of quality, it's purely a measurement of the quantity. And as I said earlier, throughout the whole of England, that percentage has been put in place by the Chief Dental Officer. And when I say minimum, that's the absolute minimum throughput in terms of numbers we would expect the practice to deliver. Many practices are delivering a higher percentage than that, but of course they have to do it. They have to determine that and clinically safely deliver services. So we'll find that many practices that have many dental suites, many chairs, find it easier in this COVID world to be able to deliver services than if it's a single-handed dentist with just one dental chair. They would find the throughput of patients slightly more slower than some of the bigger providers with many dental chairs. But it will depends on the primary care estate as well. It depends whether the surgery has an outside-facing window, or whether the practice have installed air extraction units. And it's a very mixed economy with practices and practice owners learning to do what is best in this new kind of COVID situation that we have, bearing in mind that the proximity that dentists work to patients is closer than many other clinical professions. And it is really the aerosol generating procedures. When dentists use drills, Tom tells me that the particles that are made through the drills are just the perfect size to host COVID. So, of course, practices have to be very, very careful and very, very safe, both for the patient, for the clinical team, and for any patient that may come in next after the patient before. Thank you.
Do we have records of those who can have access to dental care and then go to A&E so that they have to be looked at? Do we keep records? And if we do, can we provide those records as to how we compare with neighboring boroughs? Thank you.
So unfortunately, we don't keep those comparative records at a patient level. Our hope is that patients are seen by providers in primary care, and that deals with their needs. Many patients will appear at A&E or contact NHS 111, but the signposting should be to local primary care dental practices who have the skills and the abilities to be able to treat them. One thing that we have brought into place over the last year is a trauma pilot, and I'd invite Tom maybe to explain to the committee what that involves.
Thanks, David. Yeah, so the trauma pilot is the first in the country. It includes Luton and the surrounding areas. There is a similar system in Manchester, but that's just based in a hospital, teaching hospital. So basically we know some of the most urgent and timely care is when a child, say, falls off their bike, smashes their front teeth, somebody falls over, their front teeth get smashed, people get assaulted, that sort of thing. What we've done is we've set up a pathway where everything from A&E to ambulances to police to schools to members of the public to NHS 111, all sorts, can phone a specific dedicated number, speak to a dentist who is well versed with trauma cases, and then we can highlight this case to a group of volunteer dentists across the region who are able to pick up these trauma cases, deal with them, some of whom are very experienced and have got very high-tech equipment, some sort of equipment that often isn't in hospitals. So CBCT scanners giving very low dose but very high resolution. And that allows us to see what's happened and try and provide the best care for the patient in a timely manner and follow-up care. So this is something we've begun in the last 3 months, I suppose. It's still in its early phases, But what it does do is look at those most needy patients, as well as the dental strategy, which David has highlighted as well, looking at urgent patients. And we link very closely with A&E departments and that sort of thing through that, where patients get some sort of care within hospitals, but because of the nature of the care, they can't get everything they need. And so it's not unusual to get a request from the A&E doctor, nurse, surgeon, passing this patient on to us after they've done the initial stitching up of the face and that sort of thing. So so it's just one of several examples of things that we're doing and leading on in this part of the region.
Records of residents going to A&E because they don't have access to a dentist.
Well, what I could say is we don't keep records of patients in that situation, but what we do is we set up a system for urgent patients with urgent problems that, as David said, is sort of central part of the dental strategy. So what happens is, let's say a patient goes to A&E because they can't get to a dentist or find a dentist or that sort of thing. So what happens is that we've worked on the Director of Services, which is basically the way that patients move through NHS 111. And so the patient will be told to phone NHS 111. We then have got UDCs, urgent dental centres, and we've got a couple in Luton who've been incredibly active right from the very early stages, as David said. So last summer, when dentistry opened, we were the first part of the country to have urgent dental centres. And in Luton, you've had two very active, large practices seeing a lot of patients every day with urgent problems, some of whom are highlighted from A&E into the urgent dental care system. And so patients come through that and go through that system. And as we move further forwards with the dental strategy, David's highlighted, and you can see in your report, Programme 1A starts to look at formalising that in a more long-term process. And what we're starting to do, have piloted in Luton, so we know it works and it's beginning to be implemented, is that patients will be directly signposted to the practice via an email and booked into that practice's appointment book. So we'll be able to measure exactly what you've said, that patients coming from NHS, so from A&E, go through NHS 111 into a practice and they get seen. And so again, that's we understand one of the first in the country. It might not be the first, but I think it'll be the first that works. But we're working on that, and we've had one of our clinical fellows spend a lot of time on that, getting it right. That answers the question.
Thank you. Is there anyone else? Okay. Just one question. The 8 dental strategy transformation work streams, are they taking place in parallel or in sequence?
So we'll be rolling those out in sequence. 1A is being rolled out, and 1B, which is the out of hours part of that, and the others are then going to be rolled out in sequence, although some elements of them are being delivered now. For instance, the care homes initiative and the starting well, so dental checkups by one, they're already in train in embryo, but they're not yet written into the contracts of the providers. The idea is that these changes will become permanent changes within the contract. So 1A, for instance, which is a practice, can deliver up to 10% of its normal yearly contract in sessions of activity to urgent patients. That way, as Tom explained earlier, the DOS will be updated, the Directory of Services, so that when 111, NHS 111 are contacted, they will be able to signpost patients directly into the appointment books of NHS primary care dental practices that can then see and treat that patient appropriately.
Thank you. Is this dental strategy, is this part of the recovery plan from COVID, or is this being treated as something separate?
It's a very good question. So we were working on the dental strategy prior to COVID hitting, and then it was signed off in probably around the time that COVID hit. Most of the dental team were then redeployed to support the COVID inoculations of the population. They've since come back from redeployment, so we're not quite as far ahead with our strategy as we would like to be, given COVID. However, the dental strategy will aid the recovery of dentistry that's caused by COVID and the access restrictions that inevitably brought. So it wasn't done because of it, but the strategy is greatly aligned to increasing access, which is what we need, to reducing health inequalities, which is certainly what we need. And then the prevention part of the strategy will ensure that we have better oral health outcomes for our population for the money that we spend commissioning these primary care dental services.
Okay, thank you. Yeah, thanks for taking the time to come here tonight and present. Thank you. Oh,
thank you.
Sorry.
Sorry.
Yeah, just a quick going back to the minimum 60% thing. Obviously, that being a minimum, do we have any figures to what we're actually operating within the borough? Because obviously we're over 60, but what percentage are we actually operating out as of this moment in time, or do we not have those figures?
There is a lead lag in dental data. So when a dentist sees a patient, they have 2 months, up to 2 months to submit. It's called an FP17 form, but it's basically the details about that patient and what dentistry the patient's received. So usually there's a lag of about 3 months or a quarter. So we're just balancing out last year up until the end of March. But as we get the data going forward, we can share that with you if you wish, in terms of what dental practices in your part of the region are delivering against their contract.
Thank you.
Thank you. Okay, so if we go on to item 9, the oral health needs assessment. This is Michelle.
It is me, yes, thank you, Chair. Was a bit of an echo. Our oral health needs assessment was signed off at one of our public health DMT. It gives us a picture of the oral health of our 0 to 5-year-olds in Luton and highlights some of our areas of inequality. Dental health is a really good indicator of for poor health in general. If someone doesn't see the importance of their oral health, they might not see the importance of their general health. It also highlights social care issues, poor nutrition and obesity. It's public health have a outcomes framework, and it has an oral health indicator for children aged 5 that measures tooth decay in those children. Some of the findings from the needs assessment show that our children in Luton have poorer oral health than children in the east of the region, and nationally our 5-year-olds, 38% of them are affected with poor dental health compared to 18% in the east of England. We have a greater proportion of children with decayed, missing or filled teeth. And our dental decay seems to be clustered in densely populated urban areas, and some of the wards that were highlighted in the needs assessment are Chalney, Saints, Biscuit and Dallow ward. They're the most affected wards, and their needs assessment also highlights the relationship between ethnicity and dental decay. Some of that is around health literacy and accessing sort of services. Some of the key findings from the needs assessment are will be informing our oral health action plan. Because tooth decay is largely preventable, it requires a sort of whole system approach to meet that. And the needs assessment highlighted 5 key areas that can that should be affected. So the individual's responsibility, the community, our local authority responsibility, early years and NHS England. I just wanted to highlight some of the areas that we'll be putting in the oral health action plan around our public health oral health interventions. The findings of the needs assessment showed that supervised toothbrushing in early year settings and providing toothpaste and toothbrushes to some of our more vulnerable families are good interventions, and we've continued and expanded the reach there to make sure our oral health public messages are getting out to all early years and settings and schools. There's also a key link to healthy weight, the sort of excess sort of sugary drinks and food. So we're linking in with all settings around kind of their food policies. So it's not, we're not just focusing on oral health, we're focusing on sort of their healthy lives, and the link to breastfeeding, because that has shown that breastfeeding has better outcomes for better oral health. So did anyone have any sort of questions? I've just picked out some of the, say, key findings.
Councillor Campbell.
Thank you, Chair. I am so disappointed that this subject, the amount of times this has come to this committee for the years and years and years, where children are having, some are going into hospital to have them removed under anaesthetic. And Luton is been like this for years and we don't seem to be improving. And remember, children dental service is free. So how are we letting these people know that if they keep their children healthy by taking them to the dentist to check them, then this won't happen? Are we doing this properly? Are the schools informing the parents? You know, but it's something that's come up to this committee years and years and years, even before this pandemic. And I'm very so disappointed.
It does seem to be a historic thing, so the needs assessment shows that. And that is why we're looking at some of the ways we can sort of widen our reach. So certainly in our early year settings, we have, I think, 26 sort of schools and nurseries that work with the community dental service work with. So they train staff in supervised toothbrushing and getting those key messages out. So families understand the importance of oral health and the importance of going to the dentist. Also, with although the report focuses on 5-year-olds, we need to focus on children younger than that. So that's why the health visitors are involved earlier on, giving those key messages, handing out leaflets. There's a CCS who we commission for our health visitors. They have a information on oral health there. We have Early Years Alliance that we're linking into now, and we have link workers that are going to be sort of focusing on oral health, so and trying to connect with some of the early year settings that have been difficult to kind of engage with. So we widen the reach, and also I think David before mentioned around starting well, so that first or sort of pre-birth to sort of age 2.5. We have Early Years Alliance have got Starting Well programme, which is focused on 2 of our wards at the moment in Luton, I think Dallow and Farley, and then it's going to be expanded, and they part of their programme is around oral health, so it's about that sort of prevention, getting those key messages. So you're right, it has been a historic, and the picture doesn't seem to have improved. That's why we need the action plan to kind of see where we need to make a difference. So hopefully next time it comes back, we will see a difference.
Anyone else? Just one question. How you measure the effectiveness of your literacy campaigns, your information campaigns?
Good question. Much of our sort of evaluation measurements is around on the public health outcomes framework, but public health also do a oral health survey. So, but we'll probably gather some more local intelligence. So, and probably as part of our commission services, so with Early Years Alliance, that would be one of their performance indicators. We could look at the effectiveness of the health literacy and kind of how they're getting those key public health messages across.
Yes, I think that's quite important, that if you're relying on health outcomes to measure the effectiveness, then it could be too late for a lot of people. So yeah, I think getting some idea of how the information campaign is working is quite important.
Mm-hmm.
Okay, is that everything? Okay, thank you very much, Michelle. Thank you.
That's okay.
Okay, moving on to item 10. Health Watch, Luton update on patient views. Lisa.
Yes, hello. So I'm just bringing to you Lucy's report that I believe that you guys have already had, and it was just to bring it back to to your attention and to the forefront of your minds about our report that we produced from gathering the feedback from over 200 people, and just the main points are just to ask for Scrutiny Board just to kind of keep it in the forefront of your mind to readdress any of the recommendations that we brought forward, and there's just a couple of points that are mentioned in the report that I just wanted to highlight to you. So one of them is around safeguarding. So whilst we haven't raised any safeguardings or as many safeguardings over the last few months, there has been concerns that we have taken to Luton Safeguarding Adult Board, that we have taken to ELFT Safeguarding Team, and there has been concerns with some of the inpatients on the wards in relation to self-harm and some of the behaviours that they've been displaying. We have spoken to the Safeguarding Adult Board about some multi-agency audits that they would like us to take part in, which is something that we understand is going to be looked into in the autumn. And one of the other things is that we just wanted it to be noted that in an pre-COVID world, we would have already been in and reviewed the wards to get more independent feedback. But at the moment, we are trying to do that through speaking virtually in a manner similar to this with some of the wards, but we are finding it quite tricky to get that impartial feedback from the wards when the inpatients are actually on there. We're actually hearing more from people in the community and those that are ringing us about the care of relatives that they have on the ward.
Okay. Any questions, anyone?
Chair?
Yes.
There is a comment in paragraph 10 about the need to join up a number of initiatives that are happening on mental health. So it lists them actually very helpfully. And I would concur with that there is a need to join up some of these initiatives and get some better coordinated work going. It's great that mental health is a real focus, but I just think we need to make sure that we are not duplicating or overlapping, and that it's really clear that we're using the best resources. We know from some of our work around impact of COVID that there have been more demands on mental health packages and support. So actually just making sure that the system of working is working well, it would be quite an important agenda item. So it's helpful that Health Watch had flagged that up in this report.
I think we have a recommendation that we support the proposal to readdress these further with clear timescales on completion. So I guess that's okay. Okay. And if there's nothing else, thank you, Lisa.
Thank you.
Okay, thank you. Okay, item 11, primary care GP access. Nikki.
And thank you. I think you all know me, so I'm Nikki Pillane. I'm the Director of Primary Care with the CCG and working with the ICS. Primary care access has been a regular item. So, but recognising there's a few new members, I just thought I'd just take context. Is we talk about primary care access, and within that comes primary medical services, including the GP. And it's very important I explain that. And in fairness, I think it was Tom Norfolk, it was very helpful how he had said, if you looked into a GP practice, you see, you know, we've really developed, which perhaps the dental profession haven't. And the reason, and I know I've said this many, many times in this committee, is that we recognise that the residents in Luton don't always know how to access the GP. Is that some of them haven't registered, or some have registered and they're not sure. So we just have to recognise is that it's not as straightforward for some of our residents. So we've always said, clear message, ring your GP practice if you know, or ring the 111 service. And I've been very clear to members, it isn't about ringing the 111 to make an appointment, but if you need healthcare, you can ring the 111 and it will navigate you through. As in the earlier presentation about dental, because I knew a neighbouring area had some issues with urgent primary dental care, I had done a little bit of due diligence ourselves. So I became aware that we had two very interested dentists in Luton. So when a person contacts, for example, the 111, they would be navigated, and I can say that, and I have the data if people do want that data, because the data for dental through the 111 is quite considerable actually. But we hopefully have got that pathway right. So going back onto our primary care, you can ring your GP practice if you know it. And I am aware, and we work really closely with Health Watch, so we know that of our 26 practices, sometimes it's difficult to get through onto the telephone. And the reason I say using the 111, if you need urgent medical care, there is this back office, it's called the Clinical Assessment Service, but if you're a patient phoning that number, it's all in the background, and all you know is that you will be spoken to by somebody clinical if that requires, and there's an algorithm they use. So and the reason I say it's important is access to primary care often is people who are regular users of the service. So it was really helpful hearing Health Watch's report on mental health. We know that that's quite a lot of complaints with people with mental health issues. So what we're working with and working as a system is that if you're known to have mental health issues, you can be part of, you should know how to guide yourself to that part of the team. And I know I can see Kathy's on the call. I mean, that's probably 3-4 years ago we had the mental health liaison service. So if you have arrived at the A&E department because you haven't used primary care services, we have got what we call the mental health liaison. So I'm really trying to explain that primary care access is all about systems and working. And I would really value a discussion in all the forums. It's about managing patients' expectations. So I haven't got it drilled down to a local Luton level, but on the East of England level, it's about 30% more contacts with primary medical practices. So I'm talking about primary, maybe the nurse, it may be the pharmacist, it may be the paramedic, whoever's working in primary care. So there's 31% more activity. So I just think we need to make the context. But what we equally know is that if we start working as a system and we can guide people to the right services. So I'm now going to draw you to the reports. And the reason, we'll just see how it works for this committee. So there is a primary care access group, and helpfully we have Healthwatch, for example, on that group. We have members from the CQC. We have members of the local medical committee. So it's a broad range of people, because it would be wrong of me to say that we don't have issues with primary care, but we need to work together on it. I know I was contacted by a number of you from the GP survey, and because I think that came through. So the GP survey is one aspect of us looking at access to primary care. It's about 1% of the people in Luton, so just over 2,000 people have responded. So that is not to take value of that, but we have to see it's one of our proxy measures, it's not the total one. So on the summary report on the primary care access, it's actually stated the aims of what that group is, and I'm just trying to do a bit more succinct reporting than a long paper. So on the aims and objectives, but the ones I really want to pick up is that there is a solution of immediate problems. So in the access survey, the bottom 5 practices we know about, and we are working with them, and that's where I want to be really open, transparent, and how we can support them, because each of those practices have got different issues. Some of it's telephony, and that's really why I'm trying to show on this sheet that the digital programme is a part of the system engagement for this group. Very much when we've talked in previous meetings about population health management, and what does it really mean? And it goes back to my point. We know that children, and we know that increasing numbers of children with some respiratory issues are those people coming forward. So we're using that population health management again to target. So some of the really exciting work for this in this last couple of months is about targeting with the children. So that's the primary care team, the team that I work very closely with, but absolutely working hand in glove with the children's team, and that's those in the health side, but equally in the social care side, because they often are children with other complex needs as well. So the other one I just wanted to guide to as well is that, and it's helpful because there's been questions earlier about if primary care access isn't working, people will attend the A&E, because particularly we know with our community in Luton, often people don't understand primary care, so they go to the place where they see A&E. So, and this is where I'm talking about the 111 service. And I need to be very open and frank, because we are aware that the time it takes for the telephone to be answered in Luton, if you ring the 111, some of my worst days have been, it's only 13% of people will have had it answered in 60 seconds. That is the worst day. I mean, the best we've had is about 60%. So there's some very targeted work, because as I say, primary care access is the wider. So have they not got sufficient staff? Is it because the staff are there at the wrong time? Or, so all of those areas, and I can say that the numbers, so for, and again, forgive me because I have it for Bedfordshire and for Luton, but it's about 700 calls in a 24-hour period, which is considerably more than we had pre-pandemic. But again, we're working very closely to try and target, and as much as where we can help people to help themselves, and that's where when you ring it, is if you want the mental health, you have a star option. If it's for care home work, was large numbers of our primary care access, it's a little bit less. Probably the pandemic has actually helped that element, perhaps because we've got more collaborative working. But so that's the very first sheet I just wanted to raise and take any questions. Then I would like just to explain the second one, to give that context to why I've added that to this report. So shall I just pause there for any questions on the first primary care access?
Okay.
Yeah. Question. I'm not sure whether it's within the scope of what you said. It's about the GP surgeries that has been taken over by the 16 or private companies or American companies. Do we have details as to how they're operating? Because I think there was a report by Lucas that the service is deteriorated to the extent that people just have answer machines and not being able to speak to people in surgeries. So to me, that is a situation that we don't want to see in Luton. So I'm not sure whether you are aware of that report, and if you can comment on that.
I can certainly comment. As you know, we've got 26 practices and they're working across the 5 what we call primary care networks. And we are very lucky. If you remember, we had one of the practices that we needed to find an urgent caretaker, and we had a number of primary care practices in Luton that came together. So we don't have that problem, and I can say with confidence we have a very vibrant group of 26 practices who collaborate. So at this moment in time, I have absolutely assurance to you that there is no suggestion that services are not in a condition where you've got that fear. I don't know if we've got vibrant contracts. I haven't got anybody in Luton where I've got contractual issues where I would need to be serving, summative, negative, what we call remedial action plans on contracts. So I haven't got any of those concerns to our practices in Luton. Does that?
I just want to be sure that we are not going to have this GP surgeries being taken over, and then residents will not have access to primary care. That's my fear. So are we monitoring those GP surgeries that have been taken over by these companies? That's the question. And if we do anything to make sure that we don't fall into the same trap as reported by the Look East bulletin, I think about 3 or 4 weeks ago.
And that is where I think the value of the primary care networks, because that is the resilience of a general practice is increased if they work collaboratively. So there are a number of functions. If you work collaboratively, it's far less onerous for an individual practice. So we have all 5, and I think the COVID vaccination is a really good illustration of how they have worked together, collaborated. So, and that is really where, Councillor Aggleby, I think the primary care network development. So, for example, specifically in estates, is that we are really supportive of member practices to get buildings. So we've talked previously about the primary care network gives the opportunity of additional roles. And I know we mentioned it a few months ago about the additional investment through the GP contracts was this thing called ARS, additional role reimbursements. And that's where we've got which was 2 years ago, the social care link workers, the community pharmacist, and now it's opened up. So those additional staff, and this is where it's important that we work together about and it's all about expectations and perceptions of our residents, is that if you are arriving with a musculoskeletal or back injury, is that the person you may see may be a physiotherapist, and it's about managing the expectations of patients that that's not a second-class service to the GP, and you don't have to then go to the A&E because you really think you should have seen a doctor. So it really is about that multidisciplinary team and working collaboratively together. And I think some of the really excellent work on the frailty work, where we've worked really hand in glove with the employment team, with the housing team, and it has been, well, certainly Health Watch have been very involved in that work. So that is, I think, where I'm really coming to. The primary care access is really the front door. It's a very good proxy measure, because if you can't get into the service, then clearly the patient's experience isn't going to be a good one. But many times it's families and individuals that are what you'd say they have complex issues, and they are not regular attenders really. So it's helping us collaboratively to work together. So no, I don't think, and I think that's where the primary care network support that we're putting in, particularly on the health side, so that's infrastructure, but equally support. So there's a huge amount of education and training. So training for the reception staff, because that's really the first thing that patients experience when they arrive. And that's training all the way through and really making primary care vibrant and an exciting place to work, so we attract good staff.
Sorry, Chair. So for me, you talk about PCN or primary care networks. So again, working collaboratively, do residents who have been assigned to these 5 GP surgeries still going to be allocated with them, or they're just going to be shoved to PCN so that they are lost in the system and say, or they're going to have a named surgery, a place that they have to go to?
So all patients register with a practice. So all of our 26 practices in Luton. So if I was a patient of those, I would go to my practice. Where the 5 primary care networks come into play is they support each other, but it may be, so if I was a patient at one of the practices and the PCN may choose to have one site, for example, for doing their complex diabetes work, but that will all be done in dialogue, and that's where we work with the patient reference groups. So and it may be that they, for example, one of the options, and I know it's working in Bedfordshire, is they rotate it round. So they work as a primary care network, but because they recognise access issues for patients, they will come up with solutions to meet patients' needs. So no, in answer to your question, if I'm a patient, I would see my practice, and it's how my practice works with me to get really stronger services. Because I think the important thing, remember, is a lot of the work that we've been doing within care homes, for example. So that's been one of the first areas. So if I was a resident of if I'm a patient registered with a practice and I live in a care home, the primary care network are working very collaboratively together with a community pharmacist. If patients leave hospital, with the discharge team. So that is where the primary care networks really come into their own.
Thank you. The question, Nikki. Sorry, Pat, please go first.
I think the 111 service is great, but one of the things that Health Watch picked up on their mental health visits and feedback from the wards and individuals were that when people were discharged, they didn't know who to contact, and they went through, struggled who to contact. And yet I know 111 has a mental health person there 24/7. So perhaps it needs to be publicised more, that what 111 do and things like that, so that people know that it's just not a GP access. You could have other sort of access.
Yes, yeah. And I think I'll take the point that where patients are discharged from a mental health acute unit, that there is a named person, or people are guided as to what facilities and what services they could access That's really helpful, Pat. Yeah.
Thank you. Is there a group of people, Nikki, who doesn't matter how much literature or how much contact with them you have, how much you put the message across, they're still going to expect, there's a section of population that's still going to expect to be able to ring up the GP and get an appointment that day, rather than perhaps going through 111 or whatever pathway they should be taking?
And I think it is that continuous, and I know there is, I mean, there's still posters and you see about the 111. I think the message, and this is where we really work closely, and it's in the report with the A&E delivery board, is that it's so that we've got consistent message to our patients if they're accessing. So if they access the A&E department, is that we're getting the same messages. And if you remember at the Luton and Dunstable, if you arrived at the A&E desk and it was a primary care, you would be redirected to the GP, the urgent GP clinic. So we need, and we are confident that the urgent GP clinic would give the same as somebody in, if you'd run the 111 and you've got a GP appointment. What the message is, it's got to be so easy for patients. And that's why I say that if people can't get through to the GP surgery or they don't know who they are and they ring the 111, they will be able to get, there are what we call directly bookable appointments. Patients don't need to know that, but that's what we call it. In the background, it's directly bookable. So each practice has to nominate a number of appointment slots to try and make it easy. And this is where with system players, we are looking at the what we call urgent same day appointment. So if it's urgent to you, because we know that we've got resources in the system, and it's getting the person to the right place at the right time, so that somebody with a mental health issue doesn't actually go off to the A&E, see the psychiatric liaison service, then get put to the primary care access team. It's to try and do the first time, you know, in each case. So I think, Councillor Underwood, it is just that continual comms piece. And very much front-facing clinicians and reception staff being trained to guide patients accordingly.
Okay. You talk about transparency. The system, people ring up for appointments, ringing the 111, almost not knowing how the system works. So you're talking about directly bookable appointments. So is that I don't know, is that fair? Is that a problem that's
So I think, and Healthwatch had helpfully done some work a few years ago on the 111, is what we recognise, you've got to keep it really simple to patients, but people need to know there's some key messages, and perhaps we need that comms again, that if you ring the 111 and you're clinically assessed and needing treatment that day, you will be given an appointment. It's a contractual requirement, and we will give that. But equally, we have other bookable, which is what we call non-urgent, and the 111 service, we work collaboratively. They can make those appointments for people if necessary. So it means that if you use a service and it works for you, you'll use it again. But I stress each time, we don't want to take away from practices of about a person phoning their practice. So if I had a long-term condition, say for diabetes, we want the service to be good when they ring the GP practice and they will get that appointment. And I think the issue of it is that when we've done some of the analysis, if you don't use the service for 2 or 3 years, you don't really quite know what to expect. So you're quite right. So the biggest, what we're targeting at the moment is the cohorts, as I say, children and mental health and the care homes. And it's about making progress on those areas. But yes, you're quite right. You can't do enough comms.
okay? Do you want to carry on?
Yep. So the only reason I've given you this what we call GP community pharmacy consultation service. When you see it as an acronym, it takes a little while to sort of unpick, but it's just to give you an illustration of that collaboration where I was mentioning about the primary care access. So this is something, so for in Luton, our biggest practice, Leavale, have joined the pilot. and it's only just, so we're 1 month in. So it's an illustration of, and my role is to facilitate and to encourage within the primary care network, because the primary care network ultimately is the population in that network, so that this consultation service is trying to get collaboration between a GP practice and the local pharmacist. So local pharmacists are highly trained people with, you know, great qualifications and a great resource to the residents in Luton. So, and that is, I just wanted to give you that illustration that if people have got minor illness and it can be managed by local community pharmacists, this is where we're working at Luton at the moment to mobilise something it's an evidence-based intervention. It's been piloted nationally, so it's best practice, and that's what we're doing. So of our 26 practices, I would like to sit here and I should be able to give you a time, and perhaps I should do one for next time, of which date we have all 26 practices signed up, and that would really show that a primary care network is developing and giving excellent services. And we mentioned the dentist earlier. There's no reason why your dentist wouldn't be part of your primary care network, because they are at the moment doing some great work in Luton with the care homes. So that is a real illustration of access in primary care. So thank you.
Yes, Laura.
Chair, I wonder if it would be helpful for the group to give Nikki an insight into some of the questions and things that you're being asked by residents, so that she can, next time she feeds back on this, give you that richer picture. So I think some of the issues that are being raised by members is not actually about 111, because I think that people have got that. It's the access to GPs for people with long-term conditions and the process that they go through. So there's a bit of there are probably some more detailed questions that would be helpful, and also help. And I think the point is that for certain, if you might have an expectation that if you're phoning, you would eventually get to speak to a doctor, and it's that point you raised that actually it might be better for you to speak to a physiotherapist or to do something different. But that's not what we've all been growing up with, is it? We expect to speak to a GP, and I think there's probably a bit about, is there information that you can provide to this group that would help in getting some of those messages across, and some of the, you know, what's happening in Luton?
So I would absolutely welcome, because that would be the agenda of this working group. And Nina Pearson is our clinical lead within the transformation and really supporting that PCN. So to be honest, that's an excellent, because that almost gives us our syllabus really for what we need to crack. So thank you.
Yes, yeah, I agree.
So shall we come up with some? We can do this by email. I've come up with some questions then that would then target what you reported back on, and it would be a good, and that can then feed back on what Health Watch are picking up as well, because you'll be getting the same concerns that we're hearing, and then that will be a responding, and we can look at that and move the discussions further.
Okay, so emails to Nikki then about any issues with access. Yep, okay, thank you.
Can I just, this is a standing item on the agenda. So in other words, it comes up at every meeting. So do you want to formalise this question to go to Nikki, so that the report can actually address them in writing, and then obviously it can be discussed at the meetings?
Shall we see how this exercise goes this time, then see about formalising it? Yeah, okay, thank you.
Well, it would mean you would get a richer picture of the things that you were interested in, and that could then change. So it could be that your theme for when we've had a look at the questions is what's actually happening within the system and how people are responding, and then you might choose a different area, and then that means Nikki can target the reports and the discussion to more of what you might want to listen to and talk about and debate.
Okay, so we would like emails in advance of the next meeting so that Nikki can come back next meeting. Yeah, okay. Okay, moving on to item 12. Laura.
I have been thrown a lifeline, and actually Sarah Pasey is here with much more expertise than me to present this.
Thank you. Sarah?
Thank you. Good evening. Thank you, Laura. I'm not sure whether that's right. I think that remains to be seen whether I'm an expert in it, but let's give it a go. I'm Sarah Pasey, Senior Public Health Manager here at the Council, and I commission the drug and alcohol services for Luton. And I'm here to present the Resolutions, who are our drug and alcohol provider, Q3 and Q4 data. I'm not going to go through all of the points because, as you can see, it's quite a hefty document. But what I will do is draw your attention to some highlights that I think will be of interest to you. And if you've got any questions, I can answer those at the end. So as you're aware, because we have reported to this group in the past, CGL are, or Resolutions, whichever you want to call them, are operating with COVID restrictions. They are hoping in September to start to bring the staff and the majority of the clients back into Victoria Street for face-to-face treatment. What they are going to be cautious in doing this. They are looking at assessing all of the staff, first of all, on a traffic light system to see who can come back and who needs to remain at home, who can still work from home. And then they will do the same kind of assessment for the clients. And what they will do is to get the clients who have the most complex needs coming back into the service. There has been a lot of feedback from service users about the benefits of being able to see their key workers remotely over iPads or mobile phones. So we're not going to throw the baby out with the bathwater. We're going to look at what has worked well during COVID and continue with that, but also ensure that people are having that face-to-face access as well. So there'll be a whole menu of options for people to access their treatment. One of the other things that we are looking at as well is to really increase our community arrangements for Resolutions, so that we're going to be looking at using some of the GP surgeries and Futures House and places like that to actually see clients as well. So in terms of their performance, you will see there that we have on page 1 a table with their expected performance. Over the next couple of pages, you will see, if you've read the document, that they are achieving all of their targets at the moment, apart from one, which is where they need to work with service users who have been in the system for quite some time, and also regarding their successful completions. Now, I just wanted to point out, as I did at the previous scrutiny board, they haven't actually been discharging people through the COVID, so they're not meeting that target, but that is because they've actually been keeping people in service rather than discharging them, so that they can offer them extra support. So they're not meeting that target, and it's the only one, but really it's because they're offering more support and they're not discharging people as they would previously. So as you can see on the document on page 2, they are meeting all of their performance targets. You will see regarding the harm reduction and blood-borne viruses. In addition to that, and this isn't in the report, we've also started to look at having some COVID vaccination clinics at Resolutions. Also, when the staff are working with clients, they are actually encouraging the clients to take the vaccine if they haven't already done so. if we look to page 3, which looks at the ethnicity of service users, because I know that's been a question that's been asked of me before from the board, I'd just like to mention as well that I spoke to CGL this week. And what they are planning to do is to join up lots of the services together so that there are different virtual groups that people can get onto. And it wouldn't be that you would just be talking to people in your area within that group work. You might be talking to somebody that's in perhaps one of their Tower Hamlets services. The reason for this is they can then start groups off in specialist languages for different groups within the service. So rather than how we have in the past, we've relied on group work being provided by workers in Luton who can speak different languages. We're going to be able to use that group work and have a look at what other services CGL deliver and the languages that are spoken there. So that should really offer some of our groups in Luton more access to service within their own languages. So I thought that would be an interesting point to highlight to you. In addition to the information that's in this report, I think I need to let you know as well that we have begun to look at co-location of resolution staff as well. What we are doing is we are using some of the staff from the drug and alcohol service, and we are putting those into mental health services and also into adult social care. So each of those groups would have their own drug and alcohol workers that can work with the groups in mental health and in adult social care, and hopefully be able to also improve partnership working. And we're also going to put on training as well. So the mental health staff will come into our drug and alcohol provider and offer training and vice versa. So I'm hoping that will increase the partnership working in Luton and also the training. In terms of young people, you've got the data and information there. There is a new venue that's opening up in Luton for the young persons service. It's opposite Matalan in Castle Street, and we're going to be opening that at the end of September, early October. And we're going to use the same approach with the young person service. We are looking at co-location of other services as well. We've initially had conversations with the new family partnership. We've also had conversations with Chums and also with CAMS to look at them utilising that space. So within the new service, we'll have a drug and alcohol service for young people, but we will have those services as well using the rooms so that we can have multidiscipline meetings, and again increasing that partnership working and also the training of staff as well. So that's kind of the report in a nutshell. If you've got any questions or anything that you don't understand, I'm happy to take questions, Chair.
Thank you, Sarah. Anyone? Okay. Let's see. So point 56. Is it possible you could talk a little bit more about the tree project?
The tree project. To be honest with you, I don't actually know a lot about the tree project. I think that was something that has happened recently, and I've actually been on annual leave for 2 weeks, but I'm happily will go back and find out more about that. From what I'm aware, it's a number of services that are coming together to work with young people, and they wanted that element of drug and alcohol support to be within that. But I can't give you more detail on that at the moment, but I'm happy to come back to you with that, Chair.
Yes, that'd be good. Thank you. It's just interesting that there's a multi-agency approach to that sort of issue. Yeah.
And that's what we're trying to do with a lot of things at the moment. It is that multi-agency. We know that it's not just Resolutions, our drug and alcohol provider, that can you know, are the be all and end all of drug and alcohol issues. We have to be working in partnership with all the other agencies to solve these issues in Luton.
Okay, thank you. If there's Laura, yeah.
Sarah, I think we've allocated some additional contained outbreak management fund to support additional activity in this area under our commissioning fund. Is that right?
Is that the 2 workers?
Yeah.
Yes, that's right. Sorry, I've got a bit of an echo there. Apologies. That's right. But what we're going to do with those 2 workers, Laura, is we're going to put them into adult social care because there's a great need there for them to have their own workers. We did allocate them to alcohol workers because we're very, very, very aware of the entrenched alcohol problems that our colleagues in social care see. But when I've had conversations with adult social care, they've said that they would actually prefer a substance misuse worker, so somebody that can deal with alcohol and with drug issues. So we're just in the process of recruiting for those posts now, Laura. So again, I can report back on how that's going in at the next report, at the next board.
Thanks, Sarah. I think it's just an example where we've identified there's a need. We've got some opportunities about the Contained Outbreak Management Fund, which Scrutiny reviewed in May. And that's one of the things that we talked about. So that's actually in progress.
Yes, it is, yes.
Okay, thank you, Sarah.
Thank you, Chair.
There's nothing else. The work programme. So,
Chair, usually this is the one that comes to the myself, the DSO, as per the report within the pack. The future work programme is highlighted. There are, I have to mention about one additional meeting that's been set up, as members would know, on the 23rd of August to take one item only on the update on the Contained Outbreak Management Fund, exactly what Laura just spoken about. So this will be on the 23rd of August, which is a Monday, and 6 p.m. That will also be an in-person meeting. Otherwise, the work programme was as per the report. I may say that there is a need to review it, as I've said before, and I think Laura has also done some work on this, and obviously we need to do some work outside the meeting, Chair.
Yeah, thank you, Bert. Yeah, so I guess that the primary care GP access item will be having that if we, yeah. If we have the email response. Yeah.
Chair, this point.
Yes, sorry. So the primary care GP access standing item to be reported if required. So we'll probably require that if we have the email response from members to Nikki about GP access. Yeah.
To be included on the standing item. I suppose there is a standing item, which is there at all times to receive such matters.
Yep.
So if it's in time for the written report.
So it's so that where you've got items that are coming again and repeating, that you're asking some questions that you want answered to give clearer guidance to some of the partners so that they know what the things that you're interested in would be really helpful, and then it would mean that you've got some ideas about what you want to look into in a bit more detail, and gives partners a bit of a heads up. So if we test that out on the GP practice one, which I know you've all got examples or that your constituents are saying to you, then I think that'll give Nikki a steer for that one. You've got the COVID one coming back, where I think we talked a bit more about perhaps doing a bit more on vaccination the next time it comes back. And then you begin to think about some of the questions that you want are particularly from a patient and a resident point of view, and also take into account the very rich information that you've got sitting within Healthwatch. So it's an opportunity to just get the agenda so that you're getting what you want out of it.
Chair, could I suggest that this question come through Democratic Services, i.e. myself or Eunice and Lewis, so that we can coordinate and obviously communicate with yourself, Chair, as opposed to everyone sending the questions separately to Nikki Pillane and we are outside the loop. If you agree that could be one way forward.
Is that the best way of doing it? Yep. Yep. Agreed. Yep. Okay, that's everything. Draw the meeting to a close. Thank you, everyone. Thank you, everyone.